Hey everyone, welcome back to Coursetta Nursing. My name is Wilker Patrick. I'm a nursing educator inside the Coursetta Nursing membership, where you have access to a large library of nursing notes, video lectures like this, and one-on-one tutoring. So today we're going to go over peptic ulcer disease. So we're going to go over all those concepts that you'll need to know about for your next nursing exam. If you guys haven't already, make sure you go to CoursettaNursing.com and download our free Pathophysiology concept map note template that will allow you to take notes along with this course. So let's get right into it. So peptic ulcer disease, what does that mean? So peptic is meaning stomach or duodenum. So your stomach is what collects your food that you swallow, and the duodenum is the very first portion of the small intestine. So we're talking about both those regions right there. And then ulcer. So what is an ulcer? It's a lesion. So it's like a sore. Think of it like a sore that you get that's on your skin. Well, it's essentially the same thing, but inside in your gastrointestinal lining. So these ulcers can bleed, they can cause pain, and all sorts of other issues that we're about to talk about. But let's first start with the pathophysiology of peptic ulcer disease. Now, there are other causes, but the most common one is H. pylori, which is a bacteria that can build up in your stomach lining and cause ulcer development. Now, H. pylori is a toxin to the stomach lining, so it's going to mess with these four fancy words that we're going to talk about: gastrin, pepsinogen, somatostatin, and of course bicarbonate. Now, when H. pylori enters the stomach, it starts irritating that gastric wall. And when we irritate that gastric wall, we naturally increase our gastrin. Now, gastrin is a peptide hormone that's responsible for three major functions, but one of those functions is to protect that mucosal layer, that inner lining of our stomach. Now, when the mucosal layer gets irritated, as we talked about with H. pylori entering, that gastrin is going to increase. But the other problem is gastrin also increases hydrochloric acid production, which is acidic, and number two, improving gastric motility. So this is where the issue begins. H. pylori enters the stomach, irritates that mucosal wall of the stomach, and then increases the production of gastrin, which of course is to combat that mucosal irritation by improving the mucosal growth. But the negative side of that is that we have increased hydrochloric acid, which is acidic, which could cause more damage to that mucosal lining. And then we also have increased gastric motility, which makes it more likely that that acidic content gets into the duodenum. Another negative effect that this all has is decreased somatostatin levels, which is responsible for pancreatic enzyme release into the small intestine. So in result, we have an increased chance of malabsorption. And lastly, we'll have decreased bicarbonate levels, which is the alkaline base in contrast to the acidic base. So of course, our pH content has to stay balanced in our stomach, but when we have an increased gastrin production, we have increased hydrochloric acid, which is acidic, so it's going to combat that bicarbonate level. So your bicarbonate levels will be lower. So what happens when you have a highly acidic stomach content with already irritation to that mucosal wall? You're going to have an ulcer develop. And one thing you guys will also want to note with this pathophysiology, we talked about bicarbonate levels being low. Well, bicarbonate's main role in the stomach is to produce mucus to protect that inner lining. Well, when there's decreased bicarbonate levels, you're going to have even less protection. So this is where you can see the ulcers developing. Now, if you understand the pathophysiology, the signs and symptoms will make sense to you. We talked about location, right? So the location is your stomach, duodenum, and sometimes even the esophagus, but mostly the stomach and duodenum. Now, where is that located? This is usually located in the epigastric region. Now, if we want to be really specific, it is the left epigastric region. Now, we talked about how gastrin increases gastric motility. So one of those signs and symptoms is also hyperactive bowel sounds. And we also talked about how somatostatin is decreased, so you could expect some weight loss because of malabsorption. And then anorexia is also a possibility because of the pain involved. Now let's specifically talk about pain, because this is one of the biggest notes that you'll want to write down for your nursing exam and the NCLEX, because this is reflected on all kinds of nursing scenarios. You'll get questioned about this for sure. What is the difference between gastric ulcers and peptic ulcers and the characteristics of pain? Let's first start with gastric ulcers. Now, gastric meaning stomach, right? So it is the introduction of food that drops into our GI system. So when we swallow food, this is the first organ that collects the food to begin digestion, right? So when do you think this pain is going to occur? So when we introduce food, that of course is going to increase gastrin production naturally, but we already have a high gastric production. So what happens is when we have even more gastrin production, it's going to irritate that mucosal wall. So if you have an ulcer, it's going to cause pain when you introduce food. So that pain typically happens 1 to 2 hours after eating, sometimes immediately as well. So if there is a scenario that describes a patient having GI gastrointestinal pain that's in the epigastric region right after eating or within 1 to 2 hours, then that's most likely your gastric ulcer. Now, a duodenal ulcer, which is after the stomach, can take 2 to 3 hours after eating. So when you have a scenario question that says a patient has epigastric pain 2 to 3 hours after they ate, then that is your duodenal ulcer versus your gastric ulcer, which is more immediate / 1 to 2 hours. Now, ulcers bleed, right? Well, gastric and peptic ulcers can bleed, but the characteristics, the signs and symptoms can be different. Gastric, meaning your stomach, there is likely to be a hematemesis, which is bloody vomit. Because it's right there, it can come up, especially when you have high gastric acid production, it can come up and you can see bloody vomit. That's more likely with your gastric ulcers. Versus your duodenal ulcers, that's more likely to have something called melena, which is dark black or / dark red stool that is indicating a GI bleed. So it's more likely to come out of your stool versus your vomit with a gastric ulcer. Another thing that is a characteristic about pain is when it is relieved. So gastric ulcers are not relieved by eating. That's a big thing that you'll want to write down for your nursing exams and the NCLEX. Versus your duodenal ulcers are relieved by eating. So that's something you want to write down. Hey guys, it's Will Kirkpatrick, nursing educator inside Coursera. I wanted to let you guys know that I will help you with anything you need at any time if you just send me a text at 940-218-4062, 940-218-4062. Let's get back to the video. So we talked about how H. pylori is the most common reason why we have peptic ulcer disease in the first place. It's a bacteria, it's a toxin to that inner lining of the stomach and the GI system, so it causes all those issues we mentioned earlier. What are the other causes? Well, the other causes, something that's commonly reflected on, is NSAID use. So chronic NSAID use is another possibility of peptic ulcer disease. Other causes they reflect on, so these are your risk factors, is stress, smoking, NSAID use, H. pylori, and of course, family history. So now let's go over to complications. So us as nurses, what do we need to worry about when we have a patient with peptic ulcer disease? Well, number one is an upper GI bleed, so an upper gastrointestinal bleed. So we talked about hematemesis, if you have bloody vomit, or dark black stool, so a black tarry stool is a common sign of melena. So that is your upper GI bleed. Now, of course, with bleeding, we have to watch for our hemoglobin levels. That's another thing we have to closely monitor for. So if we have a huge drop in hemoglobin, then we need to look out for signs and symptoms of upper GI bleed, which is your melena or your hematemesis. Now, another thing you need to look out for is intestinal infarction, which is like death of your bowel. So when you have an ulcer, it actually can decrease the vascular supply of nutrients and oxygen to that organ. So a sign of this would be a hypoactive bowel sound that would progress into an absent bowel sound, and that may be a sign of intestinal infarction. And then one of the worst case scenarios is perforation. So an actual hole that develops in the gastrointestinal lining. So when that happens, we could have secretions from our gastrointestinal system leak out into the tissues that should not collect that type of fluid. So when we have foreign fluid leaking into the abdomen, it can cause something called peritonitis, which is infection of the abdominal cavity. So a hallmark sign of peritonitis is your board-like abdomen. So that is a common key term that you'll want to remember for your nursing exam. Lastly, these patients are at risk for cancer. So one of those complications could be cancer. So anytime there's a chronic irritation of a tissue, it could potentially cause an irregular growth of cells, which is cancer. Now, diagnostics. What diagnostics do we use to identify peptic ulcer disease? So first of all, we'll monitor for it with a CBC. We want to watch those hemoglobin levels. If we have an unexplained cause of a hemoglobin level dropping, then we have a potential upper GI bleed. So we want to look out for, once again, your melena or your hematemesis. Typically, these patients also have a high white blood cell count because of the irritation in the inner lining of that gastrointestinal wall. You're going to have an influx of white blood cell production. Now, since this is coming from the GI tract, we may either collect emesis to test for blood or stool, so an occult blood test. Now, to actually identify it and diagnose it, we want to do an upper GI endoscopy. This is when we put a camera down through their esophagus into their stomach to look around for ulcers. Now, if they find a GI bleed, sometimes they'll be able to actually fix it right then and there with that endoscopy. All right, we're on the last section with management. So we're going to go over the management and, of course, your specific nursing interventions that we need to do. First things first is the diet. Of course, we're talking about the GI system, so we need to talk about diet. Now, if this patient has an active GI ulcer, so an active peptic ulcer, we need to do a few things. Number one is prevention. We want to avoid smoking, alcohol, anything that could potentially irritate that gastrointestinal lining. We also want to avoid caffeine because that can also increase your gastrin production. So anything that can increase gastrin production, we want to avoid. Foods, spicy and fatty foods should be avoided. Why? Well, once again, it increases gastrin production. Now with medications, the goal is to decrease the gastrin production. So we can do that with an H2 receptor blocker or a proton pump inhibitor. Typically, H2 receptor blockers are your first choice, but sometimes a proton pump inhibitor, they are much more utilized in the hospital setting because they are simply stronger. Now with these drug classes, to decrease that gastrin production, we have our H2 receptor blocker, which has a common suffix of iodine, which I like to think of as when you go dining, you dine because it's a gastrointestinal peptic ulcer medication. These medications are also used for things such as GERD as well. And then we also have our proton pump inhibitors, which is a common suffix ending with prazole. So make sure you guys write these down and remember those drug classes. Now another medication that we may give to these patients is sucralfate. Now sucralfate is actually a protectant. So think of it like it goes into our GI system and it goes and finds that ulcer and layers over it to protect that ulcer wall. So it prevents any further damage and allows our GI system to heal while we're trying to combat the actual cause. Now something you want to write down specifically for sucralfate, and this is commonly questioned about, is that sucralfate must be taken on an empty stomach 1 to 2 hours before meals. Now you may ask why. Well, if you think about it, the whole purpose of sucralfate is to protect that GI lining. So we want to introduce that first to allow that to have time to work before we introduce food, which does what? Increase gastrin production. So we don't want to give it at the same time as food because it could potentially prevent it from actually working correctly. Now, if the direct cause is H. pylori, we typically give them 2 different antibiotics and also a proton pump inhibitor. Now moving on to the last section, nursing interventions. What should we do as nurses to improve the healing of a peptic ulcer disease? Number one is promote small, frequent meals. We don't want to overload the stomach with a large meal and once again cause increased gastrin production. We want to introduce small amounts of food at a time to keep that gastrin production as low as possible. And of course, we go back to education. We want to avoid spicy, fatty foods, no alcohol, no caffeine, and no smoking. And then lastly, guys, we want to look out for those complications. Frequently monitor those bowel sounds. Look out for hypoactive or absent bowel sounds, which could indicate an intestinal infarction. Look out for signs of perforation or peritonitis, which is like a board-like abdomen. We, of course, want to monitor their intake and output very carefully because, of course, we're talking about the gastrointestinal system here. But, of course, we want to especially look out for things such as melena, which is your dark black stools, and then we have your hematemesis, which is your bloody vomit. And then make sure you're checking your labs frequently. So if you have a drop of hemoglobin, then we want to look out for anything that's indicating an upper GI bleed like we just mentioned. All right, guys, that sums up peptic ulcer disease. I hope this video helped you guys out. Thank you guys so much for watching. I'll see you in the next one. Hey guys, first of all, thank you so much for watching the video entirely through. It makes our day if we know that nursing school got a little bit easier after watching one of our videos. If you guys like this video, make sure you like it, subscribe to the channel for more, and drop down in the comments for any more ideas that you need help with nursing school. If you want to contact me personally, it's 940-218-4062. Thank you guys for watching. We'll see you in the next video.